Good afternoon. So, Lalita, share your screen.
ได้ค่ะเห็นสกรีนไหมคะ
โอเคค่ะยานิน นัท อินซินี มุก พัชราพร right? Trisha, where is Trisha?
สวัสดีค่ะ
Okay. Trisha is here. Okay. So let's start.
Okay, good afternoon. So today I'll be talking about the soft tissue injury with practical points focusing on sports injury.
Yes.
So first I'll be talking about the types of injuries that occur in sports. So injuries in sports can occur as traumatic accidents or from overuse. So overuse will generally lead to stress fractures, which occurs in athletes who repeatedly use that type of limb or muscle for a repeated amount of time, or like especially in increased exertion, they can cause stress fractures, or in traumatic accidents where there is ligament injury, meniscus injuries, or dislocations, with the four main types of sports that are commonly referred to being contact sports, non-contact, or speed sports, or collision sports, which athletes who generally come with injuries in contact sports can be exemplified as football. In non-contact or like with overhead use of the shoulder would be like volleyball or tennis, and like speed sports where there is like agility is required and needed, such as football, or collision sports such as rugby. So after talking about each topic, I have two case examples from real life patients of Ajahn Bancha's patients. I'll be talking about, yes. So like for the injury of ligaments, we know that there's like four main ligaments in the knee, but today we'll be focusing on just the anterior and posterior ligament, while the collateral like LCL, MCL wouldn't be as much as referred to. So first is ACL injury. So I'd like to revise that there's an injury grading of ligaments, which is like the first grade is just that the ligament is just stretched, but the knee remains stabilized, and usually the ligament is only mildly damaged. So the joint is still stable and there isn't much symptoms in patients, while the second one is that there's a loosening of the ligament or a partial tear. This doesn't usually occur because either they have a grade 1 injury or just a grade 3 complete tear, which is when patients come in for some surgical operation needed. So for the ACL injury, the mechanism of the injury, in layman terms, it's usually when the athletes change their direction rapidly, like from left to right, or like there's abrupt stopping, incorrect landing from like certain positions of jumping, or having direct contact or collision to the knee. It's most commonly found in football, basketball, and badminton. And the most common mechanism that occurs is twisting, which in this twisting, the foot is generally internally rotated and there's external rotation of the tibia. So the foot and the leg is going in different directions, causing the injury of the ligament. The second mechanism would be like having stress as the valgus stress and the leg is externally rotated, or when there's abrupt stopping, which means that there's this abrupt deceleration of the movement, which causes the tibia to like become hyperly extended forward. And in these types of injury, there's usually more than one injured ligament, such as like ACL, having an associated injury with like the MCL or LCL. So 50, history and physical examination. So as like Ajahn Bancha mentioned earlier in the morning, there's a pop sound would be heard in around 50% of the cases. Patients would have extreme pain and like they would be unable to continue their play. They would have extreme swelling and discomfort upon walking or inability to like walk at all. And physical examination, as Ajahn mentioned in the morning, the tips and tricks would be to start from the least invasive test, special test, apart from the inspection, palpation, and like movement. So like the Lachman, the ballotment, the anterior drawer, the lateral pivot shift, and the McMurray test. So we all reviewed that in the morning, so I won't be talking about them in detail.
So Lalita, can you do that at the acute injury, the special test?
Sometimes that when we have history, sometimes we don't need, if the history is very concurrent to their condition, sometimes we don't need to do invasive tests. We can just do like a few like little invasive. We don't need confirmation because it's gonna cause a lot of pain to the patient.
Right. And you can cause more damage to the knee. Okay, so you should not do any invasive examination at the beginning. Okay.
So there's also this unhappy triad, which when there is 3 associated injuries that occur at the same time, which is the ACL tear, the MCL tear, and the medial meniscus tear occurring all at the same time, which causes a lot of pain and like poor prognosis of the patient. In investigation and initial management, usually we, after obtaining history taking, we don't need, like Ajahn mentioned, that we don't need much physical examination, and sometimes that we don't always need an MRI, but sometimes the MRI is used for confirmation and to see for any other associated injuries, such as we know for sure the patient has ACL tear, but we might not know if they have like a meniscus injury or not. So maybe we might need MRI for surgical evaluation. But initial management of like an ACL tear, you just have the patient to be on a cast with non-weight bearing at all for like 4 to 6 weeks and reevaluate in long term, and usually like plan for their surgical management, which is like the reconstruction or the repair.
You need casting or not for the ACL injury?
Not always, Kajan. Depends if the lifestyle of the patient and if they look like they're in a lot of pain. Sometimes that we might add a cast, but it's not always necessary.
It depends. If the patient have isolated ACL injury, we don't need the cast. You know, you just immobilize the patient for a short period, like in the soft bandage or Jones bandage, something like that. Okay, to reduce the swelling. But if the patient have the multiple ligaments like ACL injury, PCL together with the MCL, something like that, when your patient have multiple ligament, the knee will be unstable. Okay, so better put the cast on, but actually not the cast, is like a posterior slab, because if you put the cast on, you cannot monitor the distal neurovascular, right? That sometimes this kind of patient may have vascular injury. So we try to avoid the casting in the patient have the multiple ligament injury. Okay. So single ligament immobilized with soft bandage or Jones bandage is fine. Okay. If there's multiple ligament, immobilize the patient in the posterior slab in 0 degree. Okay. Not 30 degree. Many doctors put the patient in 30 degree. That's wrong, because when you put the patient in slightly flexion, if the patient have multiple ligament like PCL, the knee will drop. Like I showed you this morning, right? When you bend the knee will drop by gravity. So the patient will have subluxation of the knee inside the slab or inside the cast. Okay, very good. Let's go on.
So for PCL injury, the mechanism of the injury would be different. So the history in patients with PCL injury would be either like dashboard injuries, a injury at the hyperextended knee, or when they fall on flexion, they would give history of like these can be the history that they can give, or like fall on flexion means like ล้มเข่าพับลงไปเลยค่ะอะไรประมาณนี้ค่ะค่ะก็เป็นได้ค่ะ so the history can be both sports and dashboard injury, and the physical examination, like Ajahn mentioned today and this morning, that the tibial femoral step off should be palpated. If the patient has PCL injury, there's going to be loss of the tibial femoral step off, the Godfrey sign, which means that at the 90 degree of the flexion of the knee, you can see tibial sagging sign, which is called the Godfrey sign. And posterior drawer test can be positive, and the quadriceps active test can be positive, but mostly you would do the first three is enough for physical examination confirmation.
Sometimes just inspection, you can tell that this patient have PCL injury. Just inspection, okay, because you can see the sagging of the tibia comparing to the opposite side. Okay. Okay, good.
So for investigation in initial management, you could perform X-ray in 90 degree knee flexion, but it's not always needed. And MRI is also the gold standard for PCL as well. There's around 30% of the cases have an isolated tear, while the rest is like they have an unhappy triad associated with other meniscal injuries or other ligament injuries as well. But PCL is it has good prognosis in being self-limiting. So because the posterior ligament around the area, it has adequate synovial fluid and blood vessels. Sometimes it's in majority, most of the cases are self-limiting. So there is knee immobilization using a brace or a cast for 4 to 6 weeks, and advice for quadricep exercise is enough. And then reevaluation.
Yeah. Why the management of the PCL and ACL is different?
Because the anatomy of the PCL, where there's blood vessels and fluid, can promote better healing compared to ACL.
Yeah, right. PCL can heal, you know, because PCL is a posterior structure. It's an extra synovial structure. So very good vascular supply to the PCL. So PCL is a torn isolate. You can treat conservatively. Sometimes the PCL can heal. It's different from ACL. Okay, most of the ACL cannot heal because it's an intra-articular structure. You have synovial fluid, right? That will block the process of healing. Okay, so I said PCL can be healed. You can try the conservative treatment. Put the patient in full extension for 4 to 6 weeks. Okay. Yeah, very good.
So also at 0 degree,
0 degree. Okay, always 0 degree. So in the past, we was taught to put the cast on or slap in 30 degree. That's the old fashion, you know. And we saw a lot of complication from this 30 degree casting. Especially if you have PCL torn. You can imagine that if the patient had torn PCL or posterior capsule, when you bend the knee at 30 degree, the gravity will make PCL subluxation inside the cast. Okay, that can create the subluxation of the joint. So keep in mind 0 degree. Let's go.
But so in short, in summary, so the indications for surgical management in PCL injury. So it said that the tear is a grade 3 tear or associated with other meniscal injury or having the unhappy triad, that is when you cannot conservative and you need surgical management.
Yeah.
So a grade 3 tear means that there's posterior translation for more than like 15 millimeters.
Right.
And this is the knee immobilization in full extension, as Ajahn mentioned, in 0 degrees. And for rehabilitation, you would advise patients of quadricep exercises, and post-operation you could just do heel pumping or like even knee extension exercises, and then you would try to avoid hamstring contractions to prevent the injury to push back the knee again. Is that correct, Ajahn? I'm not sure about the hamstring. Because if you contract the hamstring a lot, I think that it will cause the injury to sublux back posteriorly.
Right. So for the PCL injury, you need quadricep exercise because the knee tend to go backward, right? If you turn PCL, the knee tend to go backward. So you need to exercise the extension to pull the tibia anteriorly forward, right? So PCL injury, you need quadriceps. If you have ACL injury, you need hamstring. Because ACL injury, the tibia tend to go forward, right? Anterior translation, like you do drawer test. So you need strong hamstring to pull the tibia back. Okay? So it's opposite. Got it? Yes.
So for this case example is a case example of an in-hospital patient of a patient who had a basketball injury with a diagnosis of ACL with a medial meniscus tear. So this patient was a 17-year-old male who had chief complaint of left knee pain and difficulty walking. So his history says that 6 months prior to admission, while playing a basketball match, he incorrectly landed on his jump with his knee internally rotated. He felt immediate pain with like unable to continue his play, and past history, no known underlying diseases, no food, drug allergy, no surgical history. Physical exam, other systems are within normal limits. And for his extremities, there is his flexion extension range of motion. His knee flexion is 160 with extension at 0 and 0 degrees. His Lachman test was positive, but his varus and valgus test was negative at 0
are you sure?
30 degrees. And his anterior drawer test was positive, but then his posterior was negative and there was no tibial sagging sign.
160, are you sure? That's a lot.
อันนี้เป็นเคสแห้งอะค่ะอาจารย์ก็คือคนไข้ไม่อยู่ก็หาจากเคสเก่าก็เลยไม่แน่ใจว่า
140, I think 160 is that's a lot. Okay.
His pivot shift was negative, but his McMurray. So this is also an example that the McMurray test can be negative for both at lateral and medial side, but then MRI revealed that he had medial meniscus tear still.
Right. As I told you, right? The cruciate ligament you can diagnose by examination or history taking, but meniscus sometimes it's not easy. You can misdiagnose. So that's why we need MRI for the meniscus injury, right? Or cartilage. But for the ligament, we can diagnose by the clinical. Okay, go on. Very good.
And then, so he came for arthroscopic ACL repair with the meniscus repair.
ACL is not repair. ACL.
Oh, ACL. Position.
No. ACL cannot repair. Reconstruction.
Oh, reconstruction.
Reconstruction. Reconstruction means you make a new one, right?
ค่ะ
Yeah, because the old one already torn. You cannot repair it like side to side repair, like tendon of the hand and foot is different. Okay, so that's the ACL patients. Okay, next.
And then so that's for the knee. In common sports injury, there's ACL and PCL, and so another common sports injury would be shoulder injury. So common accidents that happen in shoulder injuries are usually in overhead sports such as like volleyball or baseball or badminton, tennis in general. And
Like Bambi, right? Bambi had shoulder
ใช่ค่ะ
injury
อาจารย์
from tennis.
yes ค่ะ
so there can range, it can range from just like rotator cuff tendonitis or range all the way to recurrent shoulder dislocation, which is more severe, like Bambi.
Yeah. So you know which position is risky for injury? Bambi, answer the questions. Which position?
external rotation
Yeah.
with abduction of the shoulder.
Right, very good. Abduction, external rotation. ABER, we call that ABER. ABER, right? Abduction, external rotation. That's the risky position for anterior dislocation. Teacher,
ค่ะ
which position is risky to for the posterior dislocation of the shoulder?
abduction and external rotation.
Posterior dislocation.
Oh, dashboard injury.
You remember the hip joint? Hip joint posterior dislocation, which position is risky for posterior dislocation of the hip joint? Not. You remember you did the hip reduction, right, in posterior dislocation?
Right. It would be adduction and internal rotation.
Yes, very good. Tricia, remember adduction, internal rotation. Okay, same like hip joint. Same like hip joint. So it's adduction, internal rotation with the axial loading like this. Okay. If you fell on the floor and something hit onto your elbow, you can create the posterior dislocation of the shoulder also. Same like hip joint. Okay. So shoulder and hip is the same. Like anterior dislocation of the hip is the abduction, external rotation also. Okay. Very good. Lalita, continue.
So so injuries, yeah, so it's seen in overhead sports like I mentioned earlier. And for rotator, so the first condition in overhead sports we're talking about would be rotator cuff tendonitis. So it's the overuse of shoulder in overhead reaching motion, as Ajahn mentioned, or fall on outstretched arm. It can be seen associated with like other social impingement conditions, and if it occurs chronically, it can be associated and lead to rotator cuff tears. In history and physical examination, you would see that the patient has a history of chronic use or exacerbation seen in professional athletes. They can have up to night pain, and they could have audible clicking when they perform the range of movement, the range of motion of their movement, and it can lead to also weakness or limited motion of the arm, like in the case in this morning where there's pseudoparalysis as well, but that was in degeneration.
So night pain, is that common in shoulder problem?
It can be seen in if the condition is severe.
So it's very common. Most of the shoulder problem, they will have night pain, like frozen shoulder, rotator cuff tear, calcific tendinitis. Yeah. So any shoulder problem in elderly may cause night pain. Okay, so don't forget to ask the patient about night pain. Okay. Okay, very good. Next.
So physical examination in the shoulder, you would have to rule out cervical radiculopathy, and you would inspect the you would first inspect to look at the shoulder girdle for symmetry, look at the posture, look out, especially in trauma cases, look at if there's a winged scapula. You would palpate for any anterolateral tenderness and evaluate for the limited movement and the range of motion, active and then passive. And you would have to rule out cervical radiculopathy as well. So you would do it by muscle. So the supraspinatus, you could do the Jobs test, like in this morning. And for the intraspinatus, you would do external rotation stress test and the external rotation lag sign test, like this morning. And for the teres minor, you would look at the horn blower sign. And for the subscapularis, you could also evaluate by the internal rotation lag sign test. But special tests of the shoulder has many tests. So maybe sometimes if you're unsure of the diagnosis, you would have to perform many tests to help confirm your diagnosis, because not all of them are as specific as they are.
Yes.
For cervical myelopathy, you perform the Sperling test. If it's positive, it means that the pain is reproduced, and therefore they have cervical myelopathy as well. And the second condition is the recurrent shoulder dislocation, like Bambi. The most common type is the anterior shoulder dislocation, and the posterior type is only up to 2 to 5% of the cases. So as Ajahn mentioned earlier, that the mechanism would be most common at the extension of the arm and the abduction and externally rotated. And the clinical features with that, they would have severe limited range of motion, severe shoulder pain, and inability to move. And for the initial investigation as a general physician, you would have to film AP, which is the AP view. You would see that the scapula is perpendicular, and it would be as like you would see as a normal chest X-ray. But for the transcapular Y view, you would see that the scapular is making a Y shape. So this view is used to help evaluate whether that there is anterior dislocation or posterior dislocation. So usually, if there's an anterior dislocation, you would see that the head of the humerus usually moves a bit lateral, and then you would see that the head of the humerus is anterior, while the posterior dislocation, the head of the humerus moves a bit medial and it becomes posterior or looks smaller than the glenoid. So it's posterior to the Y.
So which one is easier for diagnosis? Which one is most commonly misdiagnosed? Anterior dislocation or posterior dislocation?
I think from X-ray, ใช่ไหมคะอาจารย์ Is it the anterior?
No.
No, it's posterior.
It's posterior. You know, even some orthopedic doctors still miss posterior dislocation of the shoulder. Okay, because the clinical sign is not obvious. You cannot see like deformity of the shoulder. Okay, and sometimes the patient came to see you with X-ray look very nearly normal, but it's not normal. Okay, so Lalita, please find the pictures of the posterior dislocation and share to your friends after this. Okay, so it's not easy to diagnose, but you need to know the X-ray film of the posterior dislocation. Okay, good. So the routine X-ray for the dislocation is AP and transscapular view. Do you need axillary view?
I don't think so.
Why?
I mean, I think it might be enough if you can locate where the dislocation is
Yanin,
and see that by
ask Yanin. Yanin, is that enough? 2 films? You have learned that there's 3 films, right, for the routine X-ray of the shoulder: AP, transscapular view or scapular wide view, and transaxillary view. Why 2 films is enough?
I think the transaxillary is more common for posterior, like it's better for the posterior dislocation, but it's not common. So you can detect by the first 2 films.
Yeah, the posterior dislocation is good if you use the axillary view, if you suspect the posterior dislocation. But you know, when you do axillary view, you need to abduct the shoulder. That's very painful. Very painful. So that's why most doctors not recommend to do the axillary view for the acute shoulder dislocation. You know, because you need to put the films underneath the armpit, underneath your axilla. You need to do abduction, right? That's really painful. So practically it's not easy, okay, Lalita? So that 2 films is enough. And Yanin is right. If you suspect the posterior dislocation, sometimes AP and transscapular is not clear. You need axillary view to diagnose the posterior dislocation. Okay? Okay, good point, Yanin. Next.
And so for physical examination, you would see a sign that is called empty glenoid fossa, which means that there's a palpable dent or where the head of humerus is supposed to lie, and that you could see anterior inferior deformity of dislocation where the humeral head is palpated below the coracoid process instead. So the common position of the patients appearing at the emergency department is that their arm would be held externally rotated and slightly abducted. And for the
How about the posterior dislocation? The anterior dislocation, the arm will be slightly abducted and slightly external rotation. How about the posterior dislocation? Kitty.
It will be an internal rotation and adduction.
Yeah, right. It's the opposite. Okay. So that's why we misdiagnose, because the arm position is like you put the arm sling. Adduction, internal rotation, right? Like this. Okay, like this position. So the patient cannot abduct, external rotate. Okay, like this. Okay, that's a position of the posterior dislocation. And the deformity is not obvious. Okay, very good. Next.
And so for physical examination, in terms of special tests, there are 2 big groups of special tests. There's a lax test that look at the laxity of the joint, while there's a test that look at the instability of the joint. In acute injuries, you would have to only look at the laxity signs, while in recurrent shoulder dislocations like Bambi, where there might be chronic injury and like chronic condition of the recurring dislocations, you would also have to look at the instability. So for the laxity signs, there's such signs where there is the Hamilton ruler sign, which is referring to that the acromion can basically contact the ruler, which means that there's the deltoid flattening. While the Dugar sign, which means that the patient is usually unable to touch the opposite shoulder, while and
Why is
the
Lular side positive? Because
huh?
why the Lular test positive? Go back
when
to
there's
Lular test. You see the
when
difference?
Huh.
It's positive because
the head of the humerus is
Move
pulled down,
down
move and
medial.
medial.
Yeah, when you go medial, the deltoid muscles will be flat. You see the second pictures, like nut, and nut you have big deltoid, right? So if the deltoid flat, that means the humeral head move medially. So you can put the ruler between the acromion bone and lateral epicondyl. Okay, that's because the humerus moved medially. That's why the Lular test positive. Understand? Okay, next.
And
Leukocyte and axillary nerve test.
this is important as well because the axillary nerve is an associated injury when there's shoulder dislocation. So to test the axillary nerve function, you would have to look at both the motor aspect and the sensory aspect. So you would test the pinprick sensation at the badge area of the deltoid, which is like where it's most prominent, and the motor testing is to test the deltoid contraction. In emergency management, you would have to immobilize the joint.
But in the practice, you cannot test the motor. Because painful. The patient's dislocation is very painful. So you just can test the axillary nerve, the nerve sensory, not motor. Okay. Management.
In the emergency department, the immobilization of joint is the most important concern. You would have the patient in a splint and arm sling, and you could also give them even pain control before you even have them to go film, because this is usually a purely clinical diagnosis. Like you could inspect and see the shoulder deformity in common cases, but you would film for any if you suspect any associated fractures. And it's usually a conservative management of close reduction, and this is done when there's like mostly anterior dislocation or uncomplicated posterior dislocation, and cases of no neurovascular association, injury, or fractures. So this is the modified countertraction method. That is the most common method generally used. So it's a 3-way point force, and there's 3 forces of pulling the shoulder back into the place, which the cloth underneath the axilla is used. This force performed by Ajahn Bancha is mostly used as the reversing force of the shoulder back, and there's two more helpers to help pull 2 sides as a 3-point force.
Yeah.
This method
so you know the benefit of this technique. So most of the dislocation in the young, you can use traction, counter-traction is fine. Okay, but this technique, we use it for the patient that have torn rotator cuff, the patient that have big bone defect, or the patient that have osteoporotic bone. Okay.
So good for the elderly.
Yeah, in elderly, this good for elderly, especially if you suspect that the patient have torn rotator cuff, though they have the tuberosity fracture, the gator tuberosity fracture. Because in traction counter traction, you disengage the head from the glenoid, right? And then the rotator cuff will pull the head back to the joint. In case you have no rotator cuff, okay, it's not easy to reduce the head because you have no head depressor anymore. Understand? So this the third traction, yeah, the lateral traction will help to reduce the head back. Okay, and try to avoid the leverage technique. Right, Tricia? Tricia, you attend my lecture yesterday, right? Mhm. So if you use leverage technique, what would happen?
It's at risk for fracture.
Yeah, risk for fracture. Okay, leverage technique is like mute, zero position, something like that. You have no traction force. Okay, in case the bone, the patient have poor bone quality, when you try to elevate, you can create a fracture. Okay, very good. So Lalita, let's continue.
Okay. So management, so like I mentioned, pain control and reduction, and like post reduction, you would have advised patient to avoid any external rotation abduction of the arm for 4 to 6 weeks, which this position is basically the position that they injured in, and have them on an arm sling.
So
And
now it's not 4 to 6 anymore. Lalita is too old. Yes, you just sling for a while, just for comfort. Okay,
week หนึ่งอย่างนี้ได้ไหม?
1 to 2 weeks, that's enough. When the patient get better, first time dislocation is very painful, but if the patient have multiple dislocation, I mean recurrent dislocation, the second or third episode, the patient will have pain just 1 or 2 days, you know. And you put the sling longer, is that good, Lalita?
Longer, you mean
I mean
like,
you put the sling for 4 weeks, 6 weeks, is that good for the shoulder?
No, because I don't think it's a good idea anymore, because the misuse of the arm can cause like the atrophy muscle and even frozen shoulder as well.
Yeah, stiffness of the shoulder. You put the sling longer doesn't mean that the recurrent rate will decrease. It doesn't help. Okay, so nowadays you put sling for 1 to 2 weeks, that's the maximum. Okay, so the patient most of the time they will get better after the dislocation. About 2-3 weeks they will have no pain at all. But if the patient still have pain more than 4 weeks, that means
it means that they have an unsuccessful close reduction
or
associated fracture or recurrent dislocation.
Or they may have the rotator cuff tear.
Oh.
But rotator cuff tear is not common in the young, right? It's common in
the
elderly patients. Okay, so dislocation in elderly is different from the young. Okay, if the patient older than 40, first time dislocation, thinking about the rotator cuff. Okay, like Bambi is very young, right? Bambi injury, do you have rotator cuff tear or not? Bambi, do you think you have torn rotator cuff? Yes
I don't
or no?
think so.
No, right?
No.
No cuff tear. But in the young, what will be torn? Which structure? The Bambi?
The tendon.
The capsule labrum, we call capsulolabrum of the joint. Okay, it's not rotator cuff, but the capsule of the joint. Okay, very good.
Okay, so for surgical management, usually it's due to you would do it in like unsuccessful close reduction, any concomitant dislocated fractures, or recurrent shoulder dislocation like Bambi, or any athlete or a young active individual that needs early surgery to prevent any misuse or like recurrent dislocations of their shoulder. And complication, as I mentioned, that there can be axillary nerve damage or even like avulsion fractures, joint instability in recurrent dislocations when it becomes chronic, and as I mentioned, rotator cuff injury.
In elderly.
In elderly. So this is a case that is quite common, and you could meet patients like these in the OPD or even the ER, but this patient came to the OPD because his was a recurrent case, not an acute case. So this patient was a 30-year-old male with like no underlying disease, but his chief complaint was that he had recurrent right anterior shoulder dislocation. So he gave history of up more than 10 years. He was playing badminton and his right shoulder dislocated in the position of like Yokenkun and like abducted and externally rotated. So he had up to 4 total dislocations in the past 10 years. And the most recent incident is when he was reaching backwards for an object in the car backseat. 1 year PTA, his shoulder dislocated again, which this is common in patients who have instability problems from previous recurrent shoulder dislocations, which means that there's instability problems when they don't have to move their shoulder in the externally rotated position, but maybe in just like an abnormal reaching position apart from the normal movement. It can just dislocate the shoulder from that.
Right. So the second, third, fourth episode will be easily dislocated, because the joint will be very loose, and the reduction will be easier if the patient have multiple dislocation, because the joint also very loose. Easily go out and easily get in.
And this patient, I think, was a good case for us to learn about signs of instability test, how we test instability of the shoulder. So the range of motion the patient had for a flexion of 180, abduction 180, and like internal rotation, he was able to form up to the tip of his scapula. But Salka sign was negative, but then his apprehension test was positive, relocation test is positive, and the surprising test was positive. So these 3 signs, Ajahn did it in the morning with Bambi, but then the relocation and surprising, from my understanding, is that the relocation, when you push the shoulder in the proper position, it relieves the pain. But then when you release it, having it move back to where it's painful, it will cause a pain, which gives them a surprise feeling. So it causes the surprise test to be positive.
Okay, I will send you the video. You can understand better. Okay, so it's like the patient had pain in abduction, external rotation, and then you push the shoulder back, the pain will be disappear, right? And after you release the arm again, it will surprise the patient. It's sudden pain. Okay, I send you the video. Okay, next.
But for this patient, it's a bit complicated since he received right arthroscopic Bankart repair with Remplacage procedure of the shoulder. But in acute cases, for a general physician, you wouldn't need to know as much.
Yeah, you don't need to know. Okay, you just know that how to diagnose, how to reduce the shoulder. That's enough. Okay. Very good.
And hip dislocation is the last one. For hip dislocations, the mechanism is usually in patients with in young patients with high energy trauma. So as Ajahn mentioned, the posterior dislocation would be the hip flexed and adducted and internal rotated, while the anterior would be abduction and external rotation. But it's more common in hip dislocations are more common as posterior dislocation compared to anterior, where there's only 10% of the cases.
So the hip posterior dislocation is common, right? For the shoulder anterior dislocation is common. Right? It's opposite.
So you could classify it by having a simple or complex fracture or posterior or anterior dislocation, as I mentioned. So simple is just refers to the dislocation with no fractures, while the complex means that there's both dislocation and fracture of the femur or the acetabulum as well. And this is image of Lawrence, a Thammasat fellow with a posterior dislocation.
Adduction internal rotations.
So for physical examination, you would have to test the, I'm sorry that the image is covering up the text, but the hip and leg, you could see that they are in slight flexion, adduction, and internal rotation. You generally wouldn't need to perform any special tests, since with history and like the presentation inspection of the patient presenting to the ER can be can give it away. But then you could also perform like sciatic nerve injury testing, or which is to evaluate if there's any associated injury at the straight leg resting test.
No.
And
No. You must not do this test.
You must not do this test.
You must not do that. It's so painful, you know.
Oh.
Just you move the hip is very painful. That is for the spine test, like this herniation.
Oh.
Okay. You just test the foot. Is a foot drop or not? That's enough.
Oh, okay.
Okay. No straight leg lessing test. Okay.
Okay.
So some student answer me straight leg lengthening test to test the nerve, sciatic nerve. That's wrong. Okay. Just testing the foot drop.
And you could also, but you would have to also examine knee for any associated injury or instability as well.
Yeah. Which ligament is common? Associated with the hip dislocation. Which one? Direct contact dashboard.
Oh, PCL.
Yeah, very good. PCL. Okay. So don't forget to test the PCL after you reduce the hip. It's very common.
For investigation in hip dislocation, you would have the patient in film. You would have to look at the AP of both hips and lateral cross table film of the side that is the suspected injury. Since it's better to see the dimension of the limbs, and sometimes you would also have to ask for CT post reduction to determine any associated fractures or a soft tissue injury. I'm sorry, I think I wrote it wrong. And
No, you're not wrong. Fracture, associated fracture. CT scan for associated fracture like acetabular fracture, or there's some loose body inside the joint. Okay. CT scan is for bone. It's not for soft tissue.
MRI.
Yeah, MRI for soft tissue.
And so signs to look for on the X-ray film. So you could see the Shenton line right here, and the location of the size and the location of the femoral head to determine if there's anterior or posterior dislocation.
This picture is a hip dysplasia. It's not a hip dislocation. Lalita.
I just saw that.
Yeah.
Through the Shenton line.
Right.
And the management for GP, you would know that they need an emergent reduction in 12 hours, and usually it's done in the OR because they need adequate analgesia and like pain control. So usually the patient is sedated. And sometimes for operative in cases of associated fractures, you would need like operation like ORIF or arthroscopy. And so for complications from hip dislocations, like there can be arthritis, which is like post-traumatic arthritis, or like femoral head osteonecrosis, sciatic nerve injury, or even recurrent dislocations.
So femoral head necrosis associated with the timing. Okay, so you should reduce the hip as soon as possible. Otherwise, you have higher chance of the vascular necrosis.
And that's it for today.
Okay, very good. So give a big hand to your friends. Open microphones. Very good. So I think the quiz will be on Wednesday. Okay, Wednesday at night time. You okay?
คุยเรื่องอะไรบ้างคะอาจารย์
มุกว่าเรื่องอะไรล่ะคะ
ไม่รู้ค่ะอาจารย์
ก็เรื่องที่เราจะเรียนจะสอบนี่แหละค่ะ common ค่ะ
common sport เหรอคะ
ใช่ค่ะ ส่วนใหญ่จะเป็น diagnosis นะคะ spot diagnosis โอเค
เก็บคะแน
เป็น นควิสในซูมเหรอคะอา
quiz
จารย์
ใน Zoom ครับ
ถามอ๋อ
โอเคนะคะ เดี๋ยวอาจารย์เราลูกเข้านอนก่อน โอเคนะคะ
ขอบคุณค่ะอา
ค่ะ
จารย์
คุณนายค่ะสวัสดี
ขอบ
ค่ะ
คุณครับ
สวัสดี
ขอบคุณ
ค่ะ
ค่ะอาจารย์